So yes, I'm Luke. If there is anyone from outside the province, I don't know. A little bit of a lighter topic, and one that I think is should be kind of interesting. So learners in the emergency department. So why do I want to cover this topic? It's something that over the last, I guess, kind of 5 years, I've sort of been thinking about and sort of read on here and there because I had some really good sort of teachers as residents and as staff kind of coming up through. And my fourth year of medical school was not that long ago, and I do remember lots of different departments that I went through that some of which I had kind of pretty poor experiences when I first walked through the door, and others I had really good experiences. And I've sort of realized that how important that sort of first 5 minutes is when someone enters the department. If they just kind of wander around and no one talks to them, and then they're handed a chart and they start, versus having a bit more of an approach to that learner in the department. So I think we have a really good opportunity to teach people in the department, and that's why I just sort of wanted to touch on a few things that may help sort of the next time you have a learner. So quick overview, I just want to go through kind of a bottom line. The adult learner in the emergency department, because it's kind of a unique situation, how we can do better, teaching on shift, giving feedback and sort of some suggestions around that, and then a summary of kind of the highlighted points that we're going to go through. So the bottom line, I think everyone sort of knows this: learning and teaching in the emergency department is not easy. It's a really unique environment in that every day we have multiple patient presentations and chances to teach. And so a lot of individuals, even if they don't have a lot of emerge interest, do like the department because they get a chance to practice their histories and physicals, especially our more junior learners. And so I think we need to realize that it is a great opportunity to sort of teach students, but recognizing there's constraints from the department side of things. So when there's a high volume of patients, and there's time constraints, or maybe there's low volume of patients and you're trying to come up with things to kind of talk about. And then from the learner side of things, you can have individuals that have a vast sort of background in emergency medicine. They've done 10 rotations, or they're a third or fourth year resident, or you can have that second year medical student that has yet to sort of cover the heart in their teaching in medical school. So you have to be able to adapt to the learner and to the department, but still knowing we have a great opportunity to teach. We just kind of have to have an approach. And so the first section I wanted to talk about was the adult learner in the emergency department, just because it's a little bit different than, say, that second year medical student who went straight from undergrad to medical school and is kind of working their way through. I like this text. I found a few open source chapters online, and it's something that I'll probably read more of in the future. And there's some, pretty big names that have edited this book, including, you can see Amal Mattu there, Scott Weingart, people that I know I consider to be, our big time teachers in emergency medicine, especially in foam med. And so the chapter that I read, I guess, a couple times was Adult Learners in the Emergency Department, because it is such a unique situation. I had a couple medical students in my class at Memorial. One was a biomedical engineer who worked for the European Space Agency for like 10 years before he got into medical school. Another one was a postdoc from MIT with a biochemistry background. And I always thought, if I have a medical student like that come through the department, how would I do things differently? Because adult learners do learn differently. So they come with this variety of previous experience that sometimes parts of it may not be that beneficial in the emergency department. But it's important to realize that these are people that have sort of ingrained personality traits and habits that you're not going to change. And by trying to change them and challenging these habits, you could sort of alienate the learner, and very quickly that relationship that you could, build the learner up with will be deteriorated, and you won't be able to improve. And so I think that, it's something that we need to sort of think about, that the variety of learners we get through here, are they sort of more on that adult learning side of things? Do they want more guidance than teaching? Do they want more coaching or facilitating than teaching? So they've have that background that they want to apply to new things, and sort of figure things out a bit more for themselves than maybe that more junior learner with less life experience. So if anyone's interested, I mean, again, there are some open source um, um, chapters for this book. It may be worthwhile to look into. So how to do better from the start. So again, from this text, this is a quote here: establishing an open and respectful relationship with the adult learner, all learners, is the most important first step in providing adult education. They have to know that you have respect for them and where they're coming from, in order to learn anything from you or sort of have respect for you. And so from all the FOAMed resources in this text, they all hit on sort of these same sort of aspects. These ones are more from the Emergency Medicine Cases podcast on learning in the emergency department, which Walter Himmel and Amal Mattu were big parts of. And so I think if you can only do one of these, orientating the learner is the most important, but hopefully you can get through these 4. So take 5 minutes to cover these topics when you have a new learner in the department. So orientate them, orientate yourself to them, and them to you, and them to the department. So if they haven't been there before, show them how the numbering of the rooms work, show them where the equipment is, and ask them where they're from, what is their background, how many rotations have they done in emergency medicine at this point. And it'll really help to sort of just begin to bridge that gap and build that relationship. I found I was pretty good at this aspect prior to reading this more, but the set expectations part was where I think a lot of us can do better. So depending on the level of the learner, what do you expect from them? What is their responsibility within the department? And what should they expect from you? So along these lines, a Med 2, your first few shifts with them, you may say, all I want you to do is to collect a really good history, and develop your presentation skills to sort of feed that back to me. I don't want you to worry about a physical exam at this point, just sort of really help them to focus in, but also let them know that you are going to be coaching them, critiquing them, whatever term you want to use, but let them know that that's why you're there. You will be providing feedback to them during the shift, and I think it is important to sort of let them know that from the start. The next one is priming the learner. So they sort of describe this as preparing them for success. I take this for me to mean, I use the terms slow it down. So as a medical student and a resident, I know at times I would sort of grab a chart and just run into the room, and you're trying to be keen. But I tell the learner it's okay for them to slow down. It's okay to look at the patient presentation, and if it's a vertiginous patient, if it's a shoulder pain, and these are topics that you haven't covered yet, or you're not sure how to perform the physical exam, that you take the time to learn about that, think about a differential, think about some questioning before you go in the room, and to slow down when they leave the room as well. Again, it's stemming from things that I did that I know did not help my learning, were to find my staff right away and present that case. And I noticed that that happens a lot with learners that I get, and they're not quite to the point that they have the story well ingrained and have a good approach. So just to take the 2 to 5 minutes after leaving the room to collect their thoughts before finding you and presenting. And then finally, diagnosing the learner. And so that's teaching to the level of the learner. I don't think that's as easy as these other ones that you can cover in the first 5 minutes. It may be in the first few patients or the first shift or two. What is your learner's style, and sort of where are they at mentally at the time? The Emergency Medicine Cases podcast uses this little table here, which I kind of liked. After a few shifts with a learner, are they unconsciously incompetent? You hope not. You hope they're more along the lines of the middle two. Are they consciously incompetent, which I think is probably where most of us, are. The seasoned staff may be that unconsciously competent individual. So I kind of like this sort of framework. I think it will help to sort of decide how you're going to approach the learner. So teaching on shift, I just want to initially touch on like why we do it. So especially the way our departments are right now, there's not as many things that are super enjoyable at times in our sort of bed blocked nursing shortage sort of environment. And there's only a few things in emergency medicine that you can do sort of above and beyond your work to sort of improve wellness. Things like calling a patient that you discharged home, following up a patient on the floor to see how they're doing. And another thing is teaching. It may be a shift that's very difficult in terms of the departmental constraints, but you taught a med student how to suture for the first time. And I mean, that can make you feel good because their excitement may rub off. So I'd encourage you to kind of approach it from that side of things, because it can, you know, help you to feel more fulfilled, I guess, at the end of a shift. Teaching on shift isn't easy, as we talked about before. So some sort of, you know, tips to help you actively engage and listen to the learner and get the most out of their presentation would be the full attention. So I sort of slipped a little bit in this in the past. In a little while, like I'd be on I3 putting in some orders, or I'd be jotting something down on a chart. I've really tried to stop that. I know I felt that as a learner, that if I wasn't getting someone's full attention, they weren't listening to me at all. So put the pen down, take a couple minutes to really listen to the learner present. If it's possible, maybe a quieter area than right at the desk. It can be a more sort of nerve-wracking environment for new learners, especially to be around other staff and other learners when they're trying to present. If you find you have a learner who is using the chart as sort of their script, maybe you take the chart and that'll help them to sort of reinforce that they need to know this by heart. And then finally, sort of guiding that student to arrive at their own conclusions, sort of helping them decide which questions they need to ask, how they're going to answer them, and not sort of providing the answers. Finally, it's sort of the 5 seconds of silence. You know, when you ask an open-ended question, leave it open for the learner to respond. And another thing I found was interesting was that the average eMERGE staff will interrupt their house staff prior to even interrupting their patients. So within a couple seconds of presentation, they're often interrupted and critiqued, where you should sort of save that for the end. The final point is just trying not to teach too much. So in that trauma patient that, you know, you want to teach on the primary survey and ATLS, the C-spine rules, the CT head rules, and fast scan, just pick one of them, or the learner is not going to take anything from it. I wanted to bring up some form of this 1-minute preceptor model because it's something I'd seen in the past and hadn't looked at for a while. And I think it pretty much summarizes this whole, I guess, talk. And if you look at anything or Google anything after this, this will definitely help you to improve a learner's experience the very first, you know, shift. One thing that most of the resources I looked at really hammer on is the step 1. So the end of the NERDS mnemonic, so nickel down, getting commitment from the learner. Depending on the level of the learner, that commitment may be as simple as what lab test do you want to order, to what is the differential and what is the disposition of the patient, but try to get some sort of commitment regardless of sort of the level of the learner. The other ones are pretty self-explanatory and can kind of go through them there on your own time. But this is something that's like a pocket card format from academic life in emergency medicine. It was adopted for emergency medicine, but wasn't sort of, I guess it wasn't bred from emergency medicine, but it certainly works in our environment. Just some quick sort of bonus tips when I was going through all this. The first one, I think it was from Scott Weingart. If he's, you know, kind of having trouble getting commitment from a learner, he says, you know, breaks it down just simply for differential generation, what could kill patients in minutes, hours, or days. And so what are the main things that you're worried about you want to rule out with your differential? I really like this one as well, the uninteresting patient, in quotations. trying to make them all interesting. So if you're doing a true RAS shift, urgent care type shift, maybe with a more senior learner, and you want to improve their learning, the simple cellulitis patient, you may suggest, what if this patient was an IV drug user? What if they were on day 3 of antibiotics and weren't getting better? So you can sort of build on these, less interesting patients, and hopefully improve the learning from that shift. And finally, the sticky note pearls. It's something that I know we've talked about before in our department, sort of the whiteboard pearls that Dr. Mathieu uses. We're not set up really well for that. If we had various stages of learners on shift at the same time, maybe a senior resident could kind of run the whiteboard in the bubble. But I think having sticky notes on the desk during a shift is something we could definitely do. And when I brought it up with different learners, residents, and medical students, they thought it'd be a good idea. Just not something I've really been able to do yet, or had the incentive to do yet. So I'm going to try and bring that in. And I encourage other people to kind of do that. I really enjoy looking at Dr. Mathieu's sort of whiteboard teaching sessions. He posts them on Twitter quite often. So finally, feedback. We want to avoid that feedback sandwich. So I included this. It's something we've all done and all had before, and it's not an adequate form of feedback. It's something that's a bit confusing as a learner, in that they're not sure if they did something wrong. You don't end up getting your point across, and it just doesn't work. So if you're struggling to figure out what you want to discuss for feedback for the individual that you're with, first ask for a self-evaluation. So get that learner to give some feedback on themselves. How do they think they did? What are their strengths? What are their weaknesses? And this may allow you to realize that what you were going to hit on, the learner already has established was a problem. Or if you didn't have anything to discuss, now you have the opportunity to do that. Once you've had
joined the meeting,
then you can go on to what was done right or what behavior to continue. Then finally, what needs to be changed. So this is the coaching, critiquing, guidance, whatever term you want to use. This is where that comes in. And so what behavior do you want to start, stop, or improve? What behavior, or like we mentioned with the adult learner, maybe habit needs to be modified. Finally, do your best to provide clear instructions around that. It's really important to keep the feedback simple. And I think if you can fit it in the little box on our ITERs, our end of shift evals easily, it's probably what you should be providing. It shouldn't be something that you have difficulty sort of fitting in that box. Something simple that the learner can do. And finally, sort of wrapping up your whole shift, and the debriefing based feedback. I kind of put these two together because it is very similar to what we do after a simulation. So what are these learning pearls, or learning points from the shift? They could be your sticky notes that you've done, or what are 3 things that the learner has taken from the shift, and suggest resources to enhance learning. And I only write one thing now. When I was going through residency, and I used to get 3 or 4 things that I should look up, I'd almost end up looking up nothing. So again, it's just keeping it simple, especially if you do get the opportunity to have a learner over an extended period of time. You can sort of build on things much easier. And then finally, really thinking about that debriefing based feedback, again, avoiding the feedback sandwich, but also these terms, the sort of the definition. It was a group out of Harvard that kind of does a major sort of simulation course. They initially were on sort of a non-judgmental type feedback. They didn't want to sort of alienate the people that they were coming and training with. But it left the learner confused as to, was it actually feedback? Was it actually something that needs to be changed? It was just sort of sugar-coated. Versus the judgmental side of things. The drug you decided to use was wrong, and you should use this. So now they've switched to sort of debriefing with good judgment. And from the pre-reading for the debriefing course coming up, I really liked this. So I've included it here, and it was to discover sort of the framework that an individual's thinking is based around, to learn better why they chose to do what they did. So going back to choosing a drug for a patient that you didn't think was appropriate. Well, maybe they, when you ask them, I noticed you use this medication. I'm curious as to why you did. Leave it open ended and sort of see their framework. They may say, "Oh, I worked with a previous staff last week, and that's what they did," and it just sort of eliminates that potential for you to just straight up say that wasn't a good idea in that judgmental type feedback, without knowing why they may have chosen to do what they did. Another part of this that I think needs to be included, and Dr. Atkinson has sent out a message recently about this, is how important it is to sort of observe a learner. In the FOAMed resources and things that I saw, were sort of standing outside the curtain or right in the room, at least once, during every shift with your learner. It's the only way to really see how they're improving, and are they doing things that you can coach them on improving or reinforce, and filling out their evaluations, in terms of the witness history, physical, the IDARs that they need. You have to take time for this, in order to do it correctly, and for the learner to get the most out of their experience. So the summary here is one that I think kind of goes with that NERDS mnemonic. So we need to coach or guide and not teach. We need to help learners come up with the questions they need to ask, guide them in ways that they answer them, whether it's by going back and talking to the patient or looking things up. We need to respect learners' previous life experience and habits, especially our adult learners that come through the department, because they're individuals that you could really easily sort of lose that relationship with if you sort of challenge them on their I guess personality and habit. Orientating the learner, I think, is probably the most important part. Right from the the new face that you see walking through the department, that you kind of help them find the staff they're working with, to providing them with a little bit of an opening at the start of the shift to get to know you and get to know the department. Again, the 1-minute preceptor model, you can just Google that. It's a quick little pocket card thing, and it will definitely help with our feedback. Finally, providing the feedback, again, not in that sandwich form, although it does make us feel better that we're not sort of making someone feel badly about what they've done on shift, but just reinforcing one behavior and then providing one piece of constructing feedback or coaching. And then finally, enjoying yourself. I mean, again, going back to the wellness side of things, there were some times that I would have a learner with me, or see that I had a learner with me on shift, and it just wasn't a day that I wanted to have someone there for whatever reason. But by the end of the shift, you were happy you did it. It ended up being a more enjoyable time. And so I think, if we develop some little approach to teaching and feedback, there'll be less sort of that feeling that you don't want to have a learner with you, and we may just enjoy it more. And so I have some references there. And the text was that Wiley link, but it's the Practical Teaching in Emergency Medicine. There's quite a few books like it, but I think this is one that I'll probably try and read a bit more in, so I can hopefully do a better job of moving the needle for learners towards being better. Is there anything anyone would like to add?